This program is brought to you by Emory University.
Good afternoon, everyone. My name is Sita Ranchad Nelson. I'm director of Emory's Institute for Developing Nations. And I want to welcome you to the fifth in our series of presentations on Ebola. The topic that we're going to focus on today highlights the perspectives and work of some of our institutional partners. We're very fortunate here at Emory to be working with a number of partners who are on the front lines of not only addressing the Ebola pandemic in West Africa and also here at Emory in the care of the patients, but who are very involved in preparedness for future pandemics as well. So we're very grateful to have them here. For those of you who have been following the series, I think you know that the series is put together with support from all of the colleges at the university. And I also want to take a moment to especially acknowledge with thanks the generous financial support of the Institute for African Studies, the Hala Institute, and if I can do this without being too awkward, my own institute, the Institute for Developing Nations. So it's taken a lot of units to pull this together, but it's out of a wonderful, generous spirit that everyone has. I want to remind you that videos of these presentations are being posted on IDN's website. If you go and click to the box that says Ebola, you can see all the videos as they're posted, and we try to get them up pretty quickly. I also want to remind you, this is what you'll see when you go there, that we have two more events in the series. On April 9th, former US President Jimmy Carter will be joining us to address the topic of Ebola, democracy, human rights, and public health. We're very thrilled that he's agreed to do this, and we've had such a wonderful response that please note we've had to move the event into the Wishcab Auditorium to hold more people. If you're interested in coming to that one, I would ask that you send us an email message through our website to RSVP because I think it's going to fill up. We really have a lot of interest in that event. And then on April 13th, we will be wrapping up this phase of the forum by highlighting some of the projects that people are working on and some discussion about what directions and where we go now, here at Emory especially. I also invite you during this session or as you ruminate about it afterwards to join the conversation on Twitter at #EmoryEbolaForum. We love to hear from you, and each of the forum sessions has actually had quite an active life out in Twitter. So please feel free to join that conversation. Today, I am really pleased to announce folks from our institutional partners at the Carter Center and also at IAMPHI, the International Association of National Public Institutes of Health, and the CDC. I'm going to introduce all of our speakers in the beginning and so that I don't need to interrupt the flow of their presentations. Our first speaker is Consuelo Campbell. Consuelo is the Associate Director for the Liberia Mental Health Program at the Carter Center. She is responsible for co-leading the planning, development, and implementation of national training, policy, and program support to expand capacity for mental health services delivery in Liberia. I also want to mention that as an ordained minister, Reverend Campbell serves the congregation of the First Baptist Church of East Point in East Point, Georgia. We're very happy to have her with us. She will be followed by Tom Crick. Tom is the Associate Director for the Carter Center's Conflict Resolution Program. He leads the center's Access to Justice program in Liberia, which focuses on strengthening the administration of justice, civic education on the rule of law, improving access to justice, and policy dialogue and reform. Tom has been instrumental in the center's election and conflict resolution projects, including peace processes in Sudan and peace-building projects in Liberia. He is a licensed mediator in the state of Georgia and also an adjunct faculty here in the Emory School of Law, where he co-teaches advanced international negotiations. Our third speaker will be Shelly Bratton. She is the CDC's Associate Director for Program Development. In this role, she also serves as the National Public Health Institute Program Lead. Her focus is on policy, congressional relations, strategic planning, and partnership development. As the NPHI lead, Bratton works closely with the Ministry of Health officials to develop plans for addressing system improvements and coordinates with internal and external partners to implement activities that strengthen national public health institutes globally. Courtenay Dusenbury is director of the International Association of National Public Health Institutes, or IANFI, their US office, which is based here at Emory in the Global Health Institute. IANFI accomplishes its goal of improving national public health systems through peer assistance evaluation, grant support, advocacy, collaboration, and sustainability. Courtenay guides the operation of IANFI's U.S. Secretariat, including public health system strengthening projects in over 35 countries in the world, including countries in West Africa and Liberia specifically, which has been affected by the Ebola pandemic. Please join me in welcoming our speakers, and Consuelo, I'll ask you to begin.
Good afternoon. Thank you, Sita and Keisha, for the invitation. I would like to begin by telling you that the Carter Center has had a longstanding presence in Liberia and has had wonderful relationships with various ministries throughout the country. And my colleague and I, Tom Crick and I, are going to share a little bit about our work in Liberia. But these are some of the programs that have been participating in Liberia since 2006. Tom is going to tell you more about his work in terms of access to justice and the response that it's had with Ebola, but our Access to Justice program has partnered with the government and communities to help create a functional and responsive justice system in historically marginalized rural communities by providing civic education, justice services, and dispute resolution capacities to customary leaders, women, youth, and by linking community interests to the public policy reform process. Our Access to Information program, which is not here today, has also been involved in the Ebola response, but they have been in the country since 2009, and they work primarily with government and civil society partners to advance the fundamental human rights of access to information for all people, with a particular focus on women at the national level and in rural areas. And particularly this program, in terms of its Ebola response, has been making sure that the people of Liberia understand how the monies coming into the country have been utilized by the government and by community partners, so that there is accountability and that there is also transparency, so that individuals really understand that these efforts are taking place in their community, in their country, and these are the ways, or have been the ways, that the government has participated and provided a response. I am going to speak about the work that the Carter Center has been doing through its mental health program in Liberia. And I specifically want to touch on the impact that Ebola has had on psychosocial health, the psychosocial needs of the country, the mental health program's response, and restoration and the way forward. So, what has been the psychosocial impact of Ebola on Liberia since August? Well, it has had a profound mental health and psychosocial impact. And many of the things that the country is experiencing now have been things that the country experienced during its past two civil wars. What has happened is that we're beginning to see that the Ebola virus has triggered many unresolved traumas as a result of the past civil wars. There have been unsurmountable numbers of individuals lost to Ebola, family members, loved ones, co-workers, community members, etc. And what we're seeing, or what they are experiencing, is that lots of people that have succumbed to the virus are being carried off in mass quantities, and they are being buried in ways that are untraditional to the practices, religious and cultural practices of the community. And so when you have that type of, those types of rituals and practices that are being abated because of a virus, this does something to the social and the psychological fabric of a country. In addition to that, we are seeing that individuals are losing income sources and valuables. So people that have contracted Ebola, as you know, are under 21 days of observation, find themselves in Ebola treatment units, or ETUs. And when they come out of those Ebola treatment units, if they have had employment going into the situation, they're finding that oftentimes the employment is no longer there when they come back to their communities. Or if they were farming, or if they were involved in some sort of labor activities, those activities are no longer what they once were prior to seeking treatment. In addition to that, individuals returning to their homes, now mind you, many of them are returning to homes finding that their spouses or their significant others, their children, or other extended family members that may have been living with them are no longer present because they too have succumbed to the virus. But they are being forced to burn all of the valuables that they have in their homes for fear of infection, the infection still being active in their structures, their living structures. And so as you can imagine, being in an environment where you are seeing death day in and day out, people that are gravely ill, only to, survive the virus, and having a bittersweet experience as a result of that, coming home to a reduced number of loved ones or family members and community members, and then having to being forcibly asked to burn your belongings has a tremendous impact on one's emotional and mental health. In addition to that, there have been compromised spiritual and religious practices and rituals. Corporate gatherings during a Sunday worship or Saturday worship service, those have also been abated as a result of Ebola. Some of the practices, such as the closeness, the hugging, the double-sided hugs of the cheek, or the handshake that Liberians are noted for, those too have been asked to be put on hold for fear of transmission. Funeral preparation and offerings of respect and honor in a way that has been customary to many Liberians has also been put on hold, as well as burial practices, and I'm sure that my colleague Tom Crick will speak to that a little bit more extensively. In addition, cultural mores and community traditions have been abated. I've touched on some of those. There's been a large amount of stigma and social distance that has resulted. What we are seeing is that individuals that are living in communities that may be getting their water from community well resources are being asked not to come to the community wells to draw their water. When they're in need of food or other types of health supplies, members of the community are not forthcoming and wanting to provide assistance. In addition to that, children have been disproportionately impacted because their family members have been quarantined. Many of their family members have died, as I mentioned. Mortality rates are very high. Education for the last 6 to 7 months has been on hold, so the school systems have not been operating since Ebola has taken hold. Immunizations have been put on hold as well, because many family members are afraid to go to the primary care centers that they have traditionally gone to receive immunizations, and as a result, they are holding back their children from being immunized. Nutrition is also a big factor here. Food is in scarce abundance right now. People do not have immediate access to food as they once did prior to the Ebola coming on the scene. And then, as I mentioned, stigma. So what has been the mental health program's response? Before I start there, I wanted to tell you a little bit about our program in Liberia and help you to understand and put it in context. We have been in country since 2010. We are invited by the Ministry of Health in 2009 to help to build Liberia's mental health infrastructure. And what we have been primarily focusing on have been three objectives or three components. The first has been trying to train a sustainable mental health workforce. Since 2010, we have been providing existing nurses and physician's assistants in a 6-month post-basic mental health training program where these nurses and physicians come together from all across the country. They are trained in a curriculum that was developed with the help of Liberian nationals as well as international consultants. One of the premier leaders in psychiatric nursing, Dr. Gail Stewart from the University of South Carolina's medical school, helped to develop the curriculum. And we've been training mental health clinicians. To date, we've trained 144, and we are obligated to the ministry through our Memorandum of Understanding to train 150. In addition to that, we've been implementing helping to implement the National Mental Health Policy and Plan, which has been rolling out across Liberia since our work in the ground or in the country. And then thirdly, we've been working to reduce stigma and empowering Liberians with mental health and mental illnesses and their family members. And this has been very important, especially as we work with Ebola survivors and family members to help them to walk and talk through their experiences as it relates to Ebola, and then helping communities to understand what Ebola is and what it isn't, and how to provide support to family members. So we've been providing support in terms of the Ebola response in 3 ways: through leadership, material distribution, and training and development. Our project lead, Dr. Janice Cooper, was seconded to the Ministry of Health in November, and she has been leading the psychosocial pillar for the country of Liberia since. Our training coordinator, Peter Musa, has been serving as chair of the training subcommittee of the Ebola Task Force Psychosocial Committee, helping to really galvanize the mental health clinicians that have gone through our training program and helping to coordinate their placement throughout the country in terms of providing supports to Ebola survivors and their family members, but specifically providing support to Ebola patients that are in the Ebola treatment units and to first responders and clinicians that are working in those environments. Additionally, we provided technical assistance back in November to the mental health officers of the U.S. Public Health Services Commission Corps that was deployed last October to Liberia. Our director, Dr. Tom Borneman, spent a day with the commissioned officers, basically giving them an overview of Liberia and a lay of the land and how the Carter Center has been involved in its work. We've also been working, training faculty members and conducting informal sessions on psychosocial responses to the regional Ebola outbreak at a workshop that was held by the Ministry of Health. And lastly, we've been exploring additional psychosocial response activities in the country. In addition to the leadership that we provided, we've been providing training and developments through technical assistance to mental health officers, I mentioned that, but then also to clinicians and social workers and others that are involved in the mental health workforce, providing them updates on the mental health psychological first aid for Ebola treatment. And so we've been doing that. We've been working in communities, providing community dialogues, providing group counseling sessions for more than 80 individuals for December. And so we've been really helping to strengthen communities and then also in turn strengthen the mental health workforce as it relates to Ebola. In addition, we hope to provide continuing education to the Liberian National Police around de-escalation practices and refreshers for our mental health clinicians. We've also helped with material distribution in the way of providing donated Clorox kits for disinfectant use in the Liberia clinics, and play therapy materials for children who are receiving care in the Ebola treatment units. Not advancing, let's see here. As I mentioned, we have 144 mental health clinicians that are deployed across the country, and nearly 20% of them have been actively engaged in Ebola treatment units throughout Liberia. In terms of the restoration and the way forward, one of the things that we are doing is that we're helping to acknowledge and plan for the psychosocial needs of the country. We know that Ebola is going to have a profound impact on the country in the years to come, and so we need to acknowledge and thoughtfully plan for the needs of the country, strengthen and help to adequately resource the public health sector, create sustainable facilities and practices so that it's just not acute care that we're providing, but long-term care over the years to come, and then to cultivate and build capacity of the workforce that currently exists in the country. At this time, I'm going to turn it over to my colleague, Tom Crick.
Thank you, Consuelo. Good afternoon, everybody. I'd like to show you a short video about our work during the Ebola crisis. Some of you who may have been at the second session would have heard Pee Wee Flamoco describe the work we've done to help the government and international partners mobilize the chieftaincy network to support the Ebola effort. Call it moving from resistance, where there was initially lack of understanding and a lack of communication between health teams and community members, moving from resistance to assistance, where in Liberia there's been this dramatic and unexpected tailing off of the Ebola disease. In large part, I think, because of the consensus that developed within communities to do the right things and to accept the advice they were getting from international partners and government. And then after that, I'd like, so that this is not just the Carter Center infomercial, just to sort of give a few of the impressions that I had as a non-public health expert observing how this massive and complicated and difficult public health response took place, and what that can tell us about the existing responses in Guinea and Sierra Leone, and about rebuilding or building health systems. So without further ado,
most of these people that were dying were the country people, were the illiterate people, people who could not read and write. And I can tell you that when you look at these kind of people, they are in the majority in that country. And if in our country here today, if you don't deal with them, things will go off here, and a lot of people will die.
First, we did an assessment, and we did some county-wide training in the 15 counties where we did Ebola 101 training with the chiefs. They were suggesting that it was better for us to go at the district level to conduct training. At the district level, you have more chiefs coming from the lower end, meaning you get chiefs from the town, the clan, you have women leaders, you have youth leaders at that level where they will be able to engage. We work with UNFPA, CDC, and WHO. All of these different partners went to the forum to explain to the chiefs. And at the same time, we were also asking the chief their role.
We also start from burying. If anyone died, we call on the burial team to come and do the burial.
Your duty is to report to the town chief. The town chief will make it his business to call to the clan chief. From the clan chief will inform the district, the paramount, and I will be informed.
This time around, They are talking, they are coordinating, the chiefs are supporting the health workers. So this way it's easier for county health team to be able to trace. And the difficult thing is to trace contacts. As you know, the virus spread through contact. That's the main mode of transmission. So if these people, for example, in all of the villages in the community, they have structures set up. If you went into a traditional setting today as a stranger, you have a stranger father. Your stranger father will have to report to the chief and say, I have a stranger. That way they know who you are, and they start to monitor your activity. If anything goes wrong while you're there, they will hold your stranger father responsible. We have very good team and very strong and committed teams, and we rely on our teamwork and the motivation the guys have to work in the field under difficult circumstances where in some of the community they have to walk, some have to go on motorbikes, some have to go on canoes.
People live in challenged areas, and I'm prepared to go through to meet with them and make sure they have access to information about health. And so even though some of the areas I travel were areas where they have not had motor road or car road region, but I managed to go through those places through crossing rivers, crossing creeks, walking through the jungle and getting to the people in those communities. Those communities have people living there, they are human beings, and so they need to have information. And more or less, they don't have access to communication in terms of radio and telephone.
And so we have a team of 3 in each region conducting training at the district level. The health ministry will provide the training. The Ministry of Health will mobilize the chief. We will provide logistics.
Ebola, we're talking about Ebola. We say that sign and symptom of Ebola. Other signs, we say weakness. We say running stomach, vomiting, the person get fever.
And one of the things that we've worked with to reinforce is the issue of coordination, the issue of collaboration. You have too many people working, too many people talking. In 2-3 months back, my issue was we should add more and talk less because we were talking plenty and we're not acting. So now you can see people doing more. Everybody putting their eyes together and everybody trying to do something now. And once we do it in a coordinated fashion, once we collaborate our efforts to be able to work together, I think we can achieve more.
The Cattle Center played an important role by bringing the chiefs together, and we know that the chiefs has power in the various districts and towns. So in this fight, they told it was that the chief would also help because back then we got feedback that the GCHV were carrying on the work, but the chiefs were not helping. Meaning that the chiefs would not allow them to contact tracing social move activities within their district because they felt they were not respected. So now, with the cattle center involvement, things are on course. The chiefs are even explaining things that they would do, work with the GCHV, come up with some of the laws, rules and regulations, and even bylaws and constitution for the violators of their various districts and towns.
While we're doing this, there are also suggestions now that we should go at a clan level because, again, the lower you go, the more people you get. And the more people you get, the more information will get up, and the more people will start to conduct themselves and try to support everything.
Because of the cattle center that we are even out here today, it got to a point that we did not even know what was happening in the counties, how our people were dying, whether our people were being educated to the danger of the disease that have come. It is cattle center who had to bring us out to expose us.
In some of the areas, you have resistance. When people went for bodies, when they were looking for sick people, they were resistant. We've been trying to work to change that, changing that resistance to assistance. So one of the things that we've been able to do from our engagement with the traditional leaders is to be able to bridge the gap between the chiefs and the health team.
Strange for me to watch this as someone who has managed peace programs, dispute resolution, worked on conflicts all my life, and to see the peace-building principles that we applied in post-conflict Liberia all of a sudden becoming extremely valuable in a completely different context. But I think one of the things that made it possible for an organization like the Carter Center to play this kind of role is because we had a long-established presence, we had an understanding of context, we had relationships that had been established at the community level as a means of trying to cement the peace. Liberia came out of one of the most brutal wars of the past in this century. About 1 in 11 people, some estimates, died. It ended when there was nothing left to loot, according to some people. And then the challenge was to reconstruct. And so we began slowly working on the justice sector, you need rule of law to have a functioning state. You need to have citizens at the community level to believe that the state is acting in their interests. And the first thing that you saw was that the state doesn't function outside of the capital, and even there's many problems with lack of resources and delivery, and that the people don't trust their government. There's a history of sort of essentially rapacious relationship between the center and the periphery. When we come to think about implementing a health response in this context, one of the first things that I heard on this side of the pond was Dr. Frieden from the CDC going to Congress to reassure the nation that we know how to deal with Ebola. There are certain prescribed steps that you take in terms of contact tracing and burial and the other elements we're all very familiar with. But then the thought that came to my mind is, yes, but how do you translate that into a way that the most rural and most poor and most, if you will, uneducated communities can embrace and accept as their own? And how can you somehow shift from a medical and science-based response to one that has to, in order to be successful, be extremely contextually nuanced? And that in some part is a story of the learning that everybody has done in Liberia with the medical professionals, wrestling with real dilemmas. How do you give medically sound advice about home care or home care kits when you want to save people's lives in real time? Do you advise them to put on use a pair of gloves if they're touching an Ebola patient? Well, if you're doing that, how do you advise them to take the gloves off? How many pairs of gloves do they need in their kit? How thick should the gloves be? So you give them chlorine in the solutions. You also need to give them rehydration fluids in these salts. All of these problems that are very hard to answer, even harder to translate into a messaging that communities can understand, but that at the same time the communities are out there solving their own problems, learning to put sort of plastic bags over their hands. How do you keep those two in sync? When the communities in Liberia were coming to us, the small NGOs, and saying, we want to go out there, we want to mobilize our neighborhood block, our church group, our customary organization. We just need small money, we need some posters. How do you get the money from literally the World Bank's coffers down to small sort of $100, $500 packages to mobilize the energy and resources of these communities? And now that we have, inshallah, a phase in Liberia where we're talking about building the health system, and we have these lessons about needing to sustain or build these sort of community relations between government, very much in the same way as you need to rebuild community trust in government for governance reasons, for justice reasons. What mechanisms can we put in place that ensure that there can be good lines of communication and feedback from the state to the communities? One of the examples Consuelo alluded to was this issue of burials. Burials were not going well prior to the mobilization of USAID-supported burial teams. And so they moved very quickly by necessity to cremations. But this had the unintended consequence of driving people away from Ebola treatment units, people hiding Ebola patients, because cremation is basically unheard of and verboten culturally. And so it took a long time to work backwards for the government and international community to hear that feedback and shift to a burial-only policy. You know, that there was there's a gap in anthropology in the response. I understand the World Health Organization through cuts, one of the first things that went was a small unit they had of anthropologists. To be able to understand at the CDC headquarters, when you're doing the whole social mobilization team are doing messaging, where can you translate those messages into words that are understood in Liberia and into vernacular? Those were the kinds of things that we were seeing just doing logistical mobilization. There are many, many other lessons. I think the most important would be that in this coming phase, for there to be a success in establishing a community surveillance system and reestablishing relationships with communities that can bring them back to do the immunizations, that can help them with the knowledge and the resources to sustain good Ebola prevention techniques. There needs to be a sort of trusted communication conduits established, and that is an extremely difficult and painstaking process, because trust is based on each action being taken and recognized as being taken and not being broken. So that would be my main takeaway, that the health response exists within this political and cultural environment. It's not a new observation, but you could see very clearly the struggles that the initial health responders faced before they were able to understand the context.
Yes, okay. Hi, good afternoon. I'm sorry I'm not standing due to several broken bones in my foot. But I do have a bib for the Boston Marathon if anybody's interested. Just see me after the presentation. Thank you for inviting us to be here today. Very quickly, we would like to talk with you about what are public health institutes, our organization, and our partnership with our colleagues at CDC, some examples of the work we've been doing related to Ebola, and some of the lessons that we've learned. And I think it's very interesting that we're following these presentations because what we're doing is working with government. And following up on what you said, we think that government has a very important role to play in civil society and also in establishing the systems that are necessary over the long term to allow people to take control over their own national strategies for public health. So what we have been doing is working as a part of an association of public health institutes around the world to do just that. So what is a public health institute? It's part of government. Our US CDC is a good example, China CDC, 18 CDC-like institutions in sub-Saharan Africa now and growing, many in Eastern Europe and in Europe. All formed together into this association. And their key role is, of course, to be the leader of public health efforts in a country, to promote evidence-based policies, and to make sure that government is providing public health services that people need. So what are these institutes? You find them in high-resource and in low-resource countries. They've developed in different ways. For example, China CDC was established more than 10 years ago as a result of SARS. In Canada, about 10 years ago, they created the National Public Health Institute of Canada, and in the UK, just 2 years ago, created Public Health England in order to have this coordinated strategy for public health. And I think that we've seen in a number of countries recently that where there have been institutes, there have generally been a more well-defined and well-organized response to Ebola. We can speak specifically to Nigeria, where the Nigeria CDC led the Ebola response effort, coordinated on the national, subnational, regional, local, community level to make sure that case was quarantined, that a strategy was in place for communicating with people, and that strategy was communicated throughout the country. Similarly, in Guinea-Bissau and Cote d'Ivoire, where the countries are putting together their own well-coordinated institutions, we saw quite a good response, a strong response from the local partners themselves, and a good strategy for dealing with outside donors who came in. We could contrast this with Liberia and Sierra Leone. In Liberia, EONFI had been communicating for several years about the possibility of a potential public health institute, but government felt at that time that there were too many different interests at work within the ministry and other institutions in the country, and didn't feel comfortable in pulling together a unified effort at that point. Similarly, in Sierra Leone, we had just done a series of workshops with colleagues from Public Health England and CDC about the need for a public health institute. We had great participation from the minister, and unbeknownst to the minister, 3 weeks later, the first cases were occurring in the country. So what are some of the core attributes of a public health institute? Like the US CDC, they're national. They focus on the major public health problems of the country, so they're quite different in scope from maybe US CDC to the Nigeria Public Health Institute. But that's, there's a transition over time that we're also seeing occurring from infectious disease surveillance and work to more comprehensive work. They're linked nationally within government and also subnationally and internationally between each other. What are their functions? Well, they're many of the same functions that we see at CDC. So they're knowing when an outbreak is occurring by monitoring population health. They have the systems in place to respond to that outbreak, outbreak response teams, coordinating with local jurisdictions. They have national laws in place and policies for quarantine and other activities that might be needed. They're doing research on what happens during an outbreak and what are the best ways to deal with it, as well as other general public health research. Doing health education and health promotion. We now see more of an emphasis in sub-Saharan Africa on road safety, chronic disease control, et cetera. And they're helping to develop the workforce. And several of our institutional members actually have schools of public health as part of their institution. So our association is based here at Emory. Our US office is part of the Global Health Institute. It was founded by Jeff Copeland, who many of you may know is the former head of the US CDC. And we started with 39 members in 2006, and we now have more than 100. Our mission is to link the groups together and to provide technical assistance and system strengthening work through our international community. So when we have a project in one institution, they're linking with another institution in a long-term twinning relationship that benefits both institutes.
Thanks, Courtney. So I'll talk a bit about CDC's program and also how CDC and EONFI work together in countries to help develop NPHIs. Certainly the focus at CDC formally began in 2011, and that was in partnership with EONFI. And I say formally because CDC's been working globally for a number of years, and even though we didn't call it NPHI development, certainly was working towards developing the public health functions. Certainly we're a small team at CDC and the Center for Global Health, and help coordinate the expertise across the agency. Within our team, we can handle some issues around surveillance, certainly thinking around organizational capacity, but also recognize that like at other NPHIs around the world, there's a wealth of expertise at the agency. And so if an NPHI that we're helping support is looking to develop chronic disease capacity, we look to those folks at CDC or other NPHIs to help provide that help. Our team is working to develop a monitoring and evaluation framework that really looks at NPHIs and helps them think about how they can measure their change over time and how they can help measure improvement over time. As Courtney was saying, we work through a systems approach to public health, so the Institute can be one part of the public health system. It might be that all the functions don't exist within that single institute, but how can it coordinate across the government and across other entities that touch public health? And certainly thinking about the U.S. government investment globally, and could an NPHI serve as the legacy once the U.S. government starts transitioning programs to governments? How do you pull all those functions together, and is an NPHI the right answer in certain countries? So in thinking about how CDC and EONFI approach a country to help strengthen or develop an NPHI, certainly, again, it's thinking about that system as a whole and pulling those pieces together as a whole. Very important to recognize this is a country's institute. It's important that they have ownership. It's about their priority setting. And as we think through improving the essential public health functions or operations, it includes what we're talking about here today as responding to those acute events like Ebola, certainly providing accurate data as quickly as possible and getting it into the hands of the policymakers or the folks that are making decisions about programs and need to do that quickly. The NPHIs allow a country, a government, to better absorb donor funds and hopefully coordinate that better. And also, as Courtney mentioned, focus on improving workforce capacity. And so as we work with a country, that initial step on stakeholder engagement is critical, and that's at all levels. Certainly as a country thinks about developing a national public health institute, has to come from the highest levels, the Minister of Health, then the Director General. We do a high level of essential public health function capacity, and that's really about priority setting. Does a country want to focus on improving surveillance? Does a country want to figure out how to link their epi in their lab? Are they focused on workforce development? Is emergency preparedness their number one priority, or there's several areas? And so we start there, trying to understand the Ministry of Health, the NPHI priorities. Then working with them, set the priorities, and then really think through a strategic plan and roadmap. Often we will talk with countries that already have high functioning systems and have capacity in many areas of the essential public health functions. And they come to us and they say, we need a roadmap. So we know where we want to go. How are we going to get there? What are some steps we should consider? What have other countries done? Really leaning on that peer-to-peer assistance that Courtney was talking about to give examples from other countries. So as I said, thinking about the methodology, that high-level input, but then really having a champion at one of the lower levels. You need someone who's going to get the work done. So the vision and mission is very important, but who's actually going to drive it? Because often developing an NPHI might involve reorganization, it might not, but it certainly involves strengthening partnerships, relationships, because public health often sits in various agencies within the Ministry of Health, but also external to that Ministry of Health. And so it's about establishing those partnerships and the person who's going to push that through and really become the driver for the change. As I mentioned, we work with the subject matter experts across CDC, pull from other NPHIs within the EONFI network, certainly supporting south-to-south collaboration wherever we can. And also recognize that in a country there's often a number of bilateral donors, multilateral donors, development agencies that have expertise in something to bring to the table, and think through a partnership plan that pulls in all the players in a country that the Ministry of Health would like to work with. And then, like any project, implement, monitor, and evaluate as needed. So certainly over time, have noticed some things that are critical for success of a National Public Health Institute to really take hold. That self-ownership, that the Ministry of Health truly does want this, whether it sits within the Ministry of Health or external to the Ministry of Health. Having the political champion, that technical expert that I mentioned, and also that shared national vision. And this is where that leader, the driver, is so important to pull the pieces together. And then, as I said, working through the strategic roadmap for implementing that vision and also pulling together funders.
Shelly. So we were asked to talk a little bit about our investment in Ebola-related activities, but this is actually for EONFI at least a little bit outside of the realm what we usually do, because normally we're working with countries in a long-term 3-7-year process. And so coming in and doing acute Ebola prevention activities was a little bit different for us. Basically involved going in and talking with our partners on the ground in government to figure out what they felt that they needed to have from us in order to combat the outbreak, and more importantly, helping to figure out whether their systems were going to be able to address some of these urgent needs. Since we began in 2006, we've helped now 13 countries to create their own institutions, and some of those institutes were the ones who were going to be most impacted by Ebola, including those in Guinea-Bissau and Cote d'Ivoire. So we felt as though it was a great opportunity to actually test some of those systems as the outbreak developed. Including leveraging funding for some of the partners. We also used our network to disseminate information across countries. We had a very lively discussion on our email listserv between countries, exchanging information, manuals in different languages, et cetera, to really help people get the information they needed quickly. We participated with our partners at CDC and WHO in some technical assistance visits to the GORN network. We provided funding to a couple institutions for quick Ebola training and prevention training. And we provided some funding to Liberia, or are thinking of it, for sample transport capacity. We've also been providing support to some of our existing institutions in the region to help with disease surveillance, strengthening activities, all of which we think have been quite successful. And probably the most important thing that we've been able to do as part of the network is to link these institutions together, both by region and by language capacity, so that people could share information, share ideas, and share success and failure stories on what had been happening in their countries.
So just to finish up, thinking about the lessons that have been learned from the outbreak that could potentially inform NPHI growth. Certainly thinking about Nigeria as the example, where they had strong systems in place to address polio, and they had a well-trained workforce working on polio, and they were able to redirect that towards the Ebola outbreak and quickly put things in place. As we all know, it sometimes takes emergencies like the Ebola outbreak to really get the attention of policymakers and to really demonstrate the importance of preparedness and the importance of preparing for a public health emergency before it happens. As Courtenay mentioned, having the EONFI network in place where these NPHIs could share information, manuals, communications, this has worked, this hasn't, was really important, certainly in the early phases of the outbreak. And I think also thinking about NPHI development in these countries where they're starting with very little capacity in place is that growth from a single program focus. So just like CDC started in the 40s, building upon malaria control program and has grown over the last 60 years from that, thinking about in these countries, could they grow from an infection control program, get really good at one thing, whether it's infection control or something else, and then grow from there, prove successes in one area, justify the existence of the NPHI, and then expand out from there. Thank you.
We have time for a few questions. We may go 5 minutes over or something like that.
The preceding program is copyrighted by Emory University.